Good morning or afternoon or evening, everyone, wherever you are in the world. So it's my real great pleasure to introduce today Dr. Connolly and Dr. Pislaru to talk about a topic that I think I find it very exciting, which is bioprosthetic valve thrombosis and diagnosis and management. So both of them will talk during the presentation. So how did you start? So the floor is yours, and thank you very much for joining us in our rounds.
Thank you so much, Rafa, for the introduction and also for the invitation to be here. And Soren and I will talk to you a little bit about bioprosthetic valve thrombosis, as mentioned. Neither of us have any disclosures. I'm just trying to advance here. There we go. No disclosures with regard to this presentation. And the learning objectives for the presentation are to describe what we know about bioprosthetic valve thrombosis, to discuss what we've learned recently, and to outline what we still don't know. And as per my routine, I'm going to start with a case. This is a patient that really emphasized to me the importance of this topic. So 45-year-old woman, history of congenitally corrected transposition. She underwent systemic atrioventricular valve replacement. And I'll see if my arrow works. You can see here that she presents 6 months after systemic AV valve replacement for routine follow-up and is asymptomatic. And you can see that the bioprosthetic valve demonstrates leaflet thickening and abnormal motion, and that there's clearly flow acceleration across the prosthesis. And even if this is somewhat overtraced, clearly her gradient is markedly elevated. Baseline gradient at hospital dismissal was 4 millimeters of mercury, and now it was estimated in the 16 to 18 millimeter mercury range. And we went on to transesophageal echocardiography in this patient, and we can see both of the visualized cusps are markedly thickened with reduced mobility. And one can say there's almost a fluffy and abnormal appearance to this particular cusp. And then again, the gradient was markedly elevated here, a measurement of 23 millimeters of mercury related to the increased heart rate. So again, 6 months post AV valve replacement for congenitally corrected transposition, asymptomatic. And I think one could think, what should we do next with this patient? Reoperation, valve-in-valve, blood cultures and antibiotics, or medical therapy? And I think you need to take it into context. How does the patient present? And then decide what to do. She very much did not want to stay in the hospital. She said, I feel so well, I just can't imagine myself being in the hospital. So I gave her low molecular weight heparin, first injection right away, and started her on warfarin, and then stopped, of course, the low molecular weight heparin once she was therapeutic. She returned for reevaluation 4 weeks later, and of course, I communicated with her in the interim. And we can see here on the transthoracic echo, very striking improvement in leaflet mobility, laminar flow, and here her mean gradient has gone back to normal with 4 millimeter mercury gradient. And so I think that this demonstrated an important lesson to me, and that is that there's an opportunity here that anticoagulation can work in patients with bioprosthetic valve thrombosis, and it should be considered in these patients. That's not the end of the story, though. Of course, as this young woman, one might expect or wonder why she chose a bioprosthetic valve. Well, she had a pilot's license, wanted to continue to fly, wasn't able to fly when she was on warfarin. And so after a year of being on warfarin, she said, can we try to stop warfarin? So I said that I thought that was a reasonable alternative. She stopped her warfarin and came back 6 weeks later. Again, no symptoms. The gradient had gone from 4 to 8 millimeters of mercury. And we went to transesophageal echo really to confirm the diagnosis of an abnormal prosthesis. And here we can see, again, quite striking that now just that medial cusp is involved. The lateral cusp looks really quite normal. There's thickening and abnormal motion of that bioprosthetic cusp. And again, as I mentioned, an increased gradient. So Soren will talk about this a little bit more, but I think it's important to emphasize that bioprosthetic valve thrombosis can reoccur after warfarin has been discontinued, and he'll talk to you also about that a little bit more. So we re-anticoagulated her. Her gradient came back to baseline in 4 weeks. And he'll mention also about the impact of bioprosthetic valve thrombosis on durability of the prosthesis. But in this particular patient, actually, she's now 16 years post-op, and she still has that same bioprosthetic valve, and it's working quite well. So I'm going to start this presentation and then go through a few more cases, but just to emphasize, what do we know right now? Soren, I asked Rafa if it was okay if we could do this together, because he's really the person that spearheaded the series, the early series from Mayo Clinic. And this actually was his work, or is his work, published in 2014. And we had seen these clinical cases and discussed them, and then he put them together. Did a search, not just the personal communication, but a search through our ECHO database, and identified 32 patients with bioprosthetic valve thrombosis between 1997 and 2013. You can see that 15 were treated with warfarin and 17 either had surgery or lytic therapy. And important, very important from this series was that warfarin results in hemodynamic and clinical improvement and is low risk. And it should be the first line of therapy clearly for patients who are stable. Alexander Egby joined us right around that time, and as you know, he's an incredibly hard worker and very productive individual, and he put together this important series published in 2015. And this series, published in JACC in 2015, was a retrospective look at the Mayo Clinic pathology database, 397 cases between 1997 and 2013, and a few important things to emphasize. Bioprosthetic valve thrombosis had a prevalence, you could see here, of 11.6%, an incidence of 0.74%, so it really wasn't very uncommon. And then I think also very important to demonstrate from the pathology and surgical specimen here is that as we look at that specimen, there's exuberant thrombus tissue or exuberant thrombus on the downstream aspect of the bioprosthetic valve. So the lesson, one of the lessons from this series was that it's really quite common, bioprosthetic valve thrombosis. Another important lesson here from this series was that there are pretty typical echocardiographic features that we should be on the lookout for. Increase in gradient greater than 50% above baseline, restricted cusp mobility as demonstrated in this moving image of a mitral bioprosthetic thrombosed valve, and thickened non-calcified cusps as are seen in this case as well. Other diagnostic features should be considered, and Soren will talk to you a little bit more about transesophageal echo and CT scan and when to use these as additional supporting diagnostic techniques. And then also the response to warfarin, as we saw in our patient, really helps to confirm the diagnosis. But let's go back to the diagnostic transthoracic echo features: increased gradient, restricted cusp mobility, and thickened non-calcified cusps. If all of the three parameters are present, 72% sensitivity and 90% specificity for bioprosthetic valve thrombosis. And again, from Alexander's work, it's not surprising as we look at this, that patients with bioprosthetic valve degeneration, demonstrated in blue, present later, generally at 9 to 10 years, compared to patients with bioprosthetic valve thrombosis, where they present generally between 1 and 3 years. But I think it's also noteworthy that 15% of patients with bioprosthetic valve thrombosis presented after 5 years or more after initial implant. So bioprosthetic valve thrombosis may occur early, but it also may occur late. When we go through the differential diagnosis of bioprosthetic of a patient who has an elevated gradient and a bioprosthetic valve, I think we all go through this differential diagnosis. We think about degeneration, we think about pannus ingrowth, increased cardiac output, patient prosthesis mismatch, and pressure recovery, particularly for aortic prostheses. But I think this presentation, we really want to emphasize that really high on that differential should be bioprosthetic valve thrombosis, particularly in patients who have a bioprosthetic valve and those echocardiographic features and or are in the 1 to 5 year period after implantation. Because again, from Alexander's series, as we went back and looked at the echocardiograms, abnormal findings were present in all of the transthoracic echocardiograms, but were not reported in 95% of those cases. And it was either not recognizing the entity or not suspecting the entity. As emphasized, it's usually obstruction that occurs in this disorder, but regurgitation can also be present. Similarly, the transesophageal echoes, the original report suggested bioprosthetic valve thrombosis only in about 10% of patients. But as we looked at these retrospectively in a blinded way, there's no question that thrombus was present and seen in the majority of patients, particularly the AV valves, and of course, a little bit more challenging in the semilunar valves, aortic bioprostheses in particular. So as Soren likes to say, the eyes will not see what the mind does not know. And remember to keep this diagnosis in your differential for a patient who presents with an abnormal bioprosthesis. So the lesson learned here, it's not an easy diagnosis and we need to keep it in mind. Now I'm just going to share with you 2 additional cases just to demonstrate some of the challenges of this diagnosis. Again, congenital patients. This is a 34-year-old female, pulmonary atresia, intact ventricular septum, multiple operations elsewhere. Came to our institution initially with a bioprosthetic surgically implanted valve that was dysfunctional. She was treated with a valve-in-valve and a melody was placed, and then transferred back to us 14 months later in extremis. And this is her echocardiogram. Of course, challenging images. In the image on the left, we don't see the cusp motion at all. We really don't see any cusp motion in that melody valve. We can see in the image in the middle, flow acceleration and features of an increased gradient as demonstrated with a mean gradient of 15 millimeters of mercury. The patient was treated with intravenous unfractionated heparin for 5 days, and serial echocardiography demonstrated no improvement in the gradient. And so this patient went on to surgical resection. And this is the explanted melody valve. You can see exuberant thrombus on the inflow surface of the valve in the image on the left, and also, I'm sorry, on the undersurface of the valve, and then also on the inflow surface of the valve in the image on the right. And I think this also demonstrates an important lesson, and that is that anticoagulation should be tried, but it doesn't always work. The other thing that's important about this case is this is a young patient. This is not a disease just of the elderly. And these patients, we should keep this in mind. And then one last patient to present to you, and that's a 21-year-old female with a simple congenital problem, pulmonary valve stenosis. She had a balloon, and then due to longstanding severe pulmonary valve regurgitation, underwent surgical pulmonary valve replacement. 3 years after the PVR, she had what was thought to be premature pulmonary valve prosthesis stenosis and underwent valve-in-valve. And of course, in retrospect, we think that this was also an episode of valve thrombosis. She presents now 2 months after her melody with acute dyspnea, and we can see that on the image on the left, the right ventricle is really struggling. As we look at the melody valve, you can see that there's thickening and reduced mobility of the cusps there. And then flow acceleration is clearly demonstrated. And the gradient here is mean gradient of 48 millimeters of mercury in this patient whose baseline mean gradient was less than 20, it was 15 millimeters of mercury. And so here, another important lesson is that bioprosthetic valve thrombosis affects not just surgically implanted valves, but catheter implanted valves and also valves in any position, as was also nicely demonstrated by Alexander's series. And here she is 1 month after she was admitted to the hospital, intravenous unfractionated heparin, transitioned to warfarin, and 1 month later, normal RV function, normal prosthesis, disc motion, leaflet motion, and a mean gradient of 15 millimeters of mercury. And again, transcatheter or surgical valves can be affected. And I think the other important thing, again, another young patient, this patient also was on oral contraceptive therapy, and that was subsequently discontinued. She did undergo evaluation for thrombotic disorder and was found to be heterozygous for factor V Leiden. So something else that we'll hear more about later on and or discuss. So I'd like to turn it over to Soren now, and as his screen gets teed up, I just want to emphasize that he's not only a great friend and colleague, but as you saw, he spearheaded the first series from Mayo Clinic and has been integrally involved in all of the research on this topic since that time that's come from Mayo. And he's a true echocardiographer. He understands the basics and advanced imaging principles. He's just incredibly skilled at observations and taking those observations into clinical practice and changing that into impacting patient care. And as I indicated to Rafa when I asked if we could do this together, I emphasize that he's really our thought leader on this topic at Mayo. And certainly when I have any challenging cases, I go to Soren for help. So Soren, hopefully your computer is up and running.
Heidi, thank you so much for the kind introduction. Thank you also for the opportunity to speak at this webinar. And I have to disclose one thing. I'm not an adult congenital echocardiographer, so just bear with me. My images are going to be upside down and left side right because we are at Mayo Clinic. So you may need to flip them in your mind kind of mentally. So with that being said, the question is, I'll start where Heidi left it. We had all those retrospective series, and the question that we have been asked, okay, you proposed some echo criteria, and of course they work because you defined the bioprosthetic valve thrombosis based on a response. So how does that work going forward? And one thing happened at Mayo. We shared these findings with the cardiovascular community, with both surgery, cardiac surgery, and cardiology. And, we scrambled to find those 30, 40, 50 cases of bioprosthetic valve thrombosis spanning, 20 years. And shortly after discussing this with colleagues, we collected 55 cases within just 2 years. And Alexander did another excellent work on putting this together. So these are 55 cases of suspected thrombosis, and we had 43 responders, 9 non-responders, and 3 were lost to follow-up. But the message I'm trying to convey is, how did echo work? Well, if you had 3 echo criteria, the response to anticoagulation was really excellent. 38 of 39 patients responded to warfarin. If you had only 2 echo criteria, the response to warfarin anticoagulation was kind of 50%. So the lesson learned is that warfarin works in bioprosthetic valve thrombosis, and importantly, the echo criteria do work in bioprosthetic valve thrombosis. The question becomes then, what we learned recently. How common is this disease anyway? I mean, we've seen it's 10%, 11% of the valves that needed reoperation at Mayo Clinic. But if you put things in perspective and you say, gosh, you implanted thousands of valves within that frame, you've seen from Alexander's paper that the average was 0.7% as an incidence compared to the total implantation. And here is really a paper that impacted greatly the field. This is work from the TAVR group, led by Raj Makar, talking about subclinical leaflet thrombosis in patients who underwent transcatheter aortic valve replacement. And they were just bringing up also the importance of 4D CT as a diagnostic modality for aortic prosthesis. And really, I think this has changed quite a bit our diagnostic capability for this type of valves. You can see here typical hypoattenuating lesion, so thickened valve, similar similar to what we see in echocardiography, with thrombus being located on the downstream of the valve and restricted opening of the leaflets in one of our patients. They were looking at the portico valve at that time, and they noticed that the portico valve had actually a 40% incidence of valve thrombosis at 30 days, and that's the reason the trial was stopped and the valve has been redesigned since then. But looking also at their registry data in 132 patients, they said that 30% had bioprosthetic valve thrombosis diagnosed by CT. So the coming years, there were a slur of papers from various groups across the world that showed pretty much the same. Bioprosthetic valve thrombosis, if you look for it in a systematic fashion, you're going to find it. And it's not all that uncommon. These are mostly CTs done anywhere between 30 and 90 days post-implantation. And you can see that the incidence of valve thrombosis is 12, 13, 14% in a large number of patients in registries. And you know, there's always a discussion about this, and there's all our meetings, and people say, well, okay, so this is a disease of the transcatheter valves, because you remember incidence in bioprosthetic valve thrombosis in surgical valves in the Mayo series, it's 1% or less. And that was kind of sort of the prevailing opinion. And in fact, Valentin Fuster put in an audio commentary to one of our recent paper that I'm going to share with you, when he said, let's disassociate data from surgical and percutaneous valves, because these are very, very different situations. So, you know, this is one of those statements that didn't age all that well, because this is in March 2020. And then there's back-to-back papers in May and June of the very same year from both the core valve group and the SAPIEN group for the low-risk trials. And what these trials showed, amazing incidence of bioprosthetic valve thrombosis. So at 1 year in the core valve trial, if you had a TAVR, you had 31% chance of valve thrombosis. If you had surgical aortic valve replacement, 28%. So amazing. So that's 1 in 3 patients. And the same for the partner 3 trial, 20% in SAVR, 28% in TAVR, no significant difference in terms of statistical analysis. And important to remember is that none of these patients had oral anticoagulation either immediately post-implantation or at follow-up by design. So that's important to know. So very, very high incidence. So with that, I'm going to switch to one of our recent papers. What are the long-term outcomes of these events of the bioprosthetic valve thrombosis? Ioana Petrescu was a fellow here with us, and she put together this paper looking at what is the impact of oral anticoagulation in long-term. And the key questions we asked were, is there a risk associated with anticoagulation? We are going to commit these patients for longer-term anticoagulation. What are we talking about? How long should you treat? Is it going to be a 1 month, a 3 months, a long-term issue? And then finally, you know, do we really restore prosthesis longevity? For the longest time, I believed that once you treat with anticoagulation and you maintain the prosthetic motion, you just saved the day and you feel like, you know, a hero. So let's look what we did. These are all patients who were treated with anticoagulation in a prospective fashion at Mayo Clinic, so all diagnosed clinically. And the diagnosis was empirical, obviously, using the echo criteria, using clinical acumen. So we had 83 patients who were treated with warfarin anticoagulation. And then we had match controls 2-to-1 for age, gender, year of implantation, and valve position and type to try to see if there's any difference between those. Now, if you look at the patients who were treated empirically with warfarin, only about 3/4 of them responded, 62, whereas 21 did not respond. Now, in 5 of them, they did go to surgery. And in none of them there was a thrombus on the valve, so there was degeneration. So we felt those are just misdiagnosed. 16 are indeterminate. Maybe those are the non-responder, as Heidi showed you. Some people do not respond to anticoagulation. Maybe they had degeneration, who knows, but 16 indeterminate. And then the primary endpoint for the study was to look at the safety of empirical warfarin for suspected bioprosthetic thrombosis, and to look also at the long-term prosthetic viability after bioprosthetic thrombosis. So let's see what we found. This is the population, relatively young, 57 and 58. Of course, it's going to be well matched because we match for age. Again, you see that there is a host of positions, all types of valves, all types of implantations, surgical, transcatheter, everything is in there. And the good news from this study is that anticoagulation is relatively safe. So if you look just at stroke, at peripheral embolism and death, there's no significant difference if you treat your patient with warfarin. So you should not be afraid about giving your patient a major complication along those lines. But you should definitely be afraid of bleeding, which is to be expected, because in this series, we had 12% versus 2% major bleeding, including in 3 of the 21 non-responders. So if you assume that all 21 patients who were non-responder in fact had degeneration, it means we put 3 patients at risk for no good reason. And that is the reason that in our practice we insist now that you should really confirm the bioprosthetic valve thrombosis before going to empirical oral anticoagulant therapy. So you should do either a TEE or a CT, and we can discuss about when to choose what. Now, how long do you anticoagulate? And the answer to that is it's tricky. So these are the 62 patients who did respond to anticoagulation. And as you can see, 14 out of those 62 did have a second and sometimes a third and a fourth episode of bioprosthetic valve thrombosis. Important to remember is that 9 of 14 of these were actually on anticoagulation, albeit that some had experienced subtherapeutic INRs and 4 had hypercoagulable states. But really, it means 1 in 4 patients, let me say this one more time, 1 in 4 patients will experience a second episode. And because of that, in my practice, if the risk of bleeding is low, I suggest to the patient that they stay on lifelong anticoagulation, because I think 25% chance of having another event, it's not trivial. And finally, the question from the paper, do we restore prosthetic longevity? And the answer to that was not all that great. So these are the results when you take everybody. So all 83 cases, everybody who got treated. And you can see that at 10-year time, the probability of having valve replacement or valve intervention is higher for those with the bioprosthetic valve thrombosis. And you may say, oh gosh, you had 21 patients out of 83 who did not respond. Maybe it's those ones who just skew your curve. Well, let's take those who responded to warfarin and go back at 10 years, go forward at 10 years, and you can see the probability of needing valve intervention is 68% versus 24% in controls. So what we feel it happens is that really patients who have bioprosthetic valve thrombosis do experience accelerated bioprosthetic degeneration in this series. And of course, we will see what the long-term follow-up from partner and core valves trials will show at 10 years. So this is a patient of mine, and she had bioprosthetic valve thrombosis of the mitral valve, similar to what Heidi showed you, the typical appearance of the thrombus in the downstream of the valve. 30 days of vitamin K anticoagulation, now she has a very, very nice and pliable valve. And unlike the patient that Heidi showed you, who did very well 16 years post-implantation, she comes in 2017, and this time she has a thick valve, but it's a little more echo-bright. And you can see, again, there's some leaflet immobility, not the greatest T. Remember, it's several years ago, it's a different technology. But this was a degenerated valve. So the lesson from here is that really you can have one after the other. How long do you wait to say that the warfarin did work or did not work? We have one of our young residents here, Joan Nasser, who put this together and is going to be presented at AHA this year. So how long do you wait to have a clinical effect? If you take patients who did respond to warfarin and you look in time what happens to them and you say, how long does it take to restore the prosthetic function? You see that the aortic position at 6 months, only about 60% had restored function completely, whereas mitral 100%. And this is the graph showing aortic in red and mitral in blue, and this is return to normal function of the prosthesis. So it means that you need to be patient with these cases. Check response at 1 month, see that there is some sort of a response, but do not discontinue this. The full effect, especially for aortic prosthesis, can take up to 1 year to see something. A word of caution about these bioprosthetic valve thrombosis cases, and I'm going to share with you a couple of things we recently learned. So this is a patient. How early can this occur? So this is a patient of mine who had a failed tricuspid bioprosthesis, and he came in for valve-in-valve implantation. And he's a VIP person. He has all the means. He has the monitoring device for INR. So we implanted the valve on a Friday, and his INR was 1.2. He was dismissed from the hospital next day with an INR of 1.4 and a low molecular weight heparin shot, with the plan that we should let him drift up to target INR of 2 to 3 for the coming 3 months to cover while the prosthesis gets re-endothelialized. And look what happens on Tuesday. So you can see clearly that the lateral cusp and the septal cusp of the tricuspid bioprosthesis are really having reduced function. And the question is that a bad valve? Is there some sort of distortion? No, it is not. Just look again, just like in the cases that Heidi showed you, there's this echo-dense material on top of the valve, downstream of the valve. And an important clue, even if you didn't see this, just look at the color. Look where the stent is, stent here, stent here. Look how the color flow fills the void all the way to the stent on the septal side, but not on the lateral side. So you should worry always about this void in flow through a bioprosthesis, because probably it means there is an obstruction. So the lesson learned was that bioprosthetic valve thrombosis can occur really immediately after implantation. So we need to be more careful with these valves, especially on the right side. Another case, another couple of cases, these are implanted valves that are really fresh. So we are intraoperative right here. This mitral bioprosthesis has just been implanted. This is a transgastric short axis view of the valve. And as you can appreciate, one leaflet is completely immobile, one leaflet has restricted mobility, and one leaflet opens well. And I can promise you, we did not reverse it. This is coming off bypass. The ACT is about 1 billion seconds, you know, so there's no thrombus in there whatsoever. Look at this transcatheter valve just implanted. This is courtesy of Harry Shalike in Arizona. So again, the same story. One of the cusps doesn't move at all. So these are freshly implanted valves. And Joan did, again, some great work together with Sari Padang, one of our rising stars in the Echo Lab, looking at a series of patients over 10 years. They identified 30 patients who have immobile cusps right from the very beginning. So these are not necessarily thrombosed. I don't know if they would thrombose in the long run. Maybe they do. But keep in mind that you can have immobile cusp without thrombosis. And the other patient I was going to show you, this is a gentleman who is quite elderly. So he had presented with an elevated gradient across the aortic valve prosthesis, and we did this 4D CT, and you can see here thickened cusps, hypoattenuating lesion, there's restricted opening, so we understand where this is going to, and we said, okay, this is bioprosthetic valve thrombosis, put him on warfarin, except except this is one of the non-responders. It does not respond to warfarin anticoagulation. And 1 month later, he actually starts having symptoms consistent with endocarditis. He does have positive blood culture with Streptococcus salivarius. And amazingly, as soon as you start antibiotics, in addition to the anticoagulant therapy, the gradient resolved. So go figure. So that meant to us that really, if it looks like a duck, walks like a duck, and quacks like a duck, sometimes it is not a duck, you know. And it is very, very important that you culture always whenever you see thickened leaflets, because you cannot make a tissue diagnosis based on the imaging test. So keep that in mind. So if you look at the bioprosthetic valve thrombosis, the evolution of the disease is very well summarized by this PubMed publication per year between 1984 and 2000. So the 1984 was the first paper ever, first case report of a bioprosthetic valve that thrombosed. And if you look, these are the papers from our group, the first paper in the Surgical Journal, Alexander Jack paper, Raj Makar's paper in New England. And I think you can divide these interval in 3 parts. It's the first part was the unicorn, you know. We heard about this, but never ever saw a case in our lives. And then there's a long interval when the disease is ignored. We know it exists because there's several publications outlining case reports, but it's not felt to be a real clinical problem. And it's really through works from the group in TAVR and the group at Mayo and other groups across the world that shows the importance of this disease. And we realize now that this is a real problem, and we have diagnostic tools to find it, and we have therapeutic means to treat it. So that's the way the things work. What are the things that we still do not know? So a key question, is bioprosthetic valve thrombosis if you do perform oral anticoagulation post-implantation? We do not know that really. At Mayo Clinic, we are very aggressive. Our surgical group has been extremely aggressive from the get-go in putting every single patient with aortic valve replacement on warfarin anticoagulation. Of course, everybody for pulmonary, tricuspid, and mitral valve, that was the practice all along. And we feel that perhaps that is the risk, that is the reason why we see very low incidence of transcatheter aortic valve thrombosis at the Mayo Clinic. Perhaps that's the case. And of course, this will need to be done in prospective trials, and we plan to do this at the Mayo Clinic. What is the role of surveillance imaging in these patients? Remember that the ccTGA valve guidelines say that you should do an initial transthoracic, and then you should do another transthoracic echo if there is a change in signs of symptoms, or if you live to 10 years post-implantation, then you should start imaging yearly because the chance of deterioration is higher there. At the Mayo Clinic, we really go for yearly echocardiography because we feel we are going to miss a lot of the subtle cues for bioprosthetic valve thrombosis. And indeed, you probably miss 90% of the valve thrombosis if you image at the guideline indication. Can you use the novel oral anticoagulants? I think probably in the end the answer will be yes, but keep in mind there are a couple of issues. There are case reports of both success and failure with novel oral anticoagulants, and in our series actually we did have bioprosthetic valve thrombosis on patients who were on oral anticoagulants, just the same as we had bioprosthetic valve thrombosis in patients who were on warfarin anticoagulation. And also remember that the Galileo trial was stopped early because the rivaroxaban was associated with excess death and excess stroke in patients who used this agent as a strategy for anticoagulation in the 3 months post-implantation of transcatheter aortic valve. We are waiting results for apixaban, so we will see if the studies show a different picture. So let's wrap things up because it's getting late. Which are the take-home points for diagnosis? Heidi likes to say, to make a diagnosis, you first have to think about it, and I think this is the key. You had that list of mechanisms that can lead to an increased gradient of bioprosthetic valve. And reviewing our series, it is amazing to me how, in a systematic fashion, we try to talk our way out of a simple diagnosis. It's always the patient prosthesis mismatch. It's always the high flow. It's always this, always that. And hardly ever people think about bioprosthetic valve thrombosis. So think about that. Put it on the top of your differential. And the 10 things that are really important in my mind in terms of bioprosthetic valve thrombosis, these are the summary of things that Heidi showed and some of the things that I showed today. It is a common disease. It occurs up to 1/3 of the patients who have not been anticoagulated. It occurs with both surgical and transcatheter valves. It affects definitely all valve position. This is not an aortic valve disease. It happens to see more in the aortic valve just because there are more aortic valve bioprostheses. It can occur both early and late. The latest was actually 11 years post-implantation. Diagnosis is challenging. Use the echo criteria with the gradient 50% over baseline, receive cast mobility, thickened leaflets. Remember that occasionally they have regurgitation, and remember to confirm that diagnosis with a CT or TE. Anticoagulation works, but you can have bioprosthetic thrombosis while you are anticoagulated. Be patient with these cases. It's going to take a while for the gradient to return to baseline, especially in aortic position. Remember that these patients do have a risk of accelerated degeneration, so you need to follow them closely. I showed you a couple of cases of stuck leaflets, and that's a story that is evolving, and we'll see what exactly those patients do in the long term. And please, please, please do not forget to include infectious endocarditis in the differential of a thickened leaflet, because that's going to be important for your patient. I was very delighted to see that both the ACC and the European Society guidelines were changed in 2017 with based essentially on work from groups across the world, including ours. And now warfarin anticoagulation is recommended by the both societies as a strategy to treat bioprosthetic valve thrombosis. And with that, I'd like to close by saying this is not only work from Heidi or myself. There was a very large group at Mayo Clinic who shares this interest, and I would like to thank all of them for the input they had to these results and this presentation. Thank you.
Thank you very much, both of you, for an excellent, amazing presentation. So the paper is open for discussion. So if you want to ask any questions, I suggest you either unmute your microphone and ask directly the question, or you can type them on the chat, and I will ask them to Heidi. I'm sorry. So I have one question to start with. So how soon do you start anticoagulation after putting a bioprosthetic valve? Because when you have a mechanical valve, we try to start in the first 12 hours. In these cases, we do it for a slightly different reason. So how soon do you start anticoagulation after implanting a prosthetic valve, a bioprosthetic valve?
Heidi, do you want to take this or?
Yeah, so most of our patients, we would start within the first 3 days. It depends, of course, a little bit on their hemodynamic and surgical course. Of course, many of the congenital patients are reoperations. So we work with the surgeons, see the patients, monitor them, decide on an effective time, but generally within the first 3 days.
Yeah, and for the transcatheter valve, the group has been equally aggressive. So we do not use aspirin and Plavix alone. We have stopped that after coming out of the clinical trial. So every clinical TAVR has warfarin as a component unless there's a high risk of bleeding. And typically warfarin is start the day of the implantation, and then we dismiss the patient without bridging, either on single or dual antiplatelet therapy, depending on the stents, recent interventions, and so on and so forth. But it's quite common to do Plavix and warfarin for at least 3 months.
There's a question from Grushin. Hello, Grushin. So does the thrombotic load influence treatment choice?
I do not think the thrombotic load has influenced any of the cases that we've seen. The issue here is more hemodynamic stability. So I think if your patient is in shock, you're not going to start warfarin anticoagulation with little heparin bridging. You need to be more aggressive than that. And I think we had several cases where patient went straight to surgery, or cases where patient didn't want surgery and we did thrombolysis. These are really extreme cases. But if I see just a high thrombus burden, but really the patient is only class 3 symptoms, I feel very comfortable starting just the same oral anticoagulation. We classically have done warfarin alone. I don't know, Heidi, what do you think?
Well, the first patient that I presented, obviously I was quite concerned because of the high gradient. Despite her lack of symptoms, I was concerned that the next day or the next week, the gradient might be so severe that she presents in shock. And so I personally, for very high thrombus burden, prefer to start to cover them either with intravenous unfractionated heparin or low molecular weight heparin until the INR is therapeutic.
No, agree, completely agree on that.
Dr. Coleman has a question, so Jack.
Hi, good morning. That was just a fabulous presentation, and I think it's practice changing. All practice has already changed from the data you showed. So based on what we heard today, do you think that oral contraceptives are contraindicated in any woman with a bioprosthetic valve, full stop?
I purposely mentioned it in one of the patients that I presented, because I do think we need to keep that in mind. We always ask patients about contraception and family history or personal history of thrombosis, but I do think we should have an increased level of vigilance in patients who are on oral contraceptive therapy. And what I personally do in those patients is not tell them that they can't use it, but discuss alternatives. And then if they elect to stay on oral contraceptives, I would see them early after stopping anticoagulation. So let's say they have surgical pulmonary valve replacement and they're on combination oral contraceptive therapy. I treat them with 3 months of warfarin, therapeutic warfarin anticoagulation after surgical implant. And then I would see them approximately 3 months after stopping anticoagulation for a limited echo to recheck the pulmonary valve prosthesis and make sure that things are okay. Obviously, this one patient with the Melody valve presented earlier, and as I mentioned, she was heterozygous for factor V Leiden, so she had a double hit, and I think that increased her chance in that particular patient. So.
And I think it's really important to emphasize that once you have this, you start anticoagulation, but you should do reflex 2 things. One is the culture, as we discussed. The other one is the thrombophilia workup. So just like Heidi showed you, sometimes you have things that may sway you one way or the other. I didn't stop too long, but really having a hypercoagulable state was a very powerful predictor of developing a second event, as you would expect. But do this in a systematic fashion. We did not do that for the longest time, but that is our practice now.
Heidi, well, after you stop on the anticoagulation in the pulmonary valves, do you keep them on any aspirin or anything, or just follow them with no antiplatelets?
So per US guidelines, all patients with artificial valve prostheses, whether mechanical or bioprosthetic, it's recommended at this time at least to use aspirin. So we recommend aspirin in all of the patients. In fact, the patients that we treat with warfarin, we keep them on low dose aspirin as well.
Okay. So there is another question in the chat which says, what would be the best strategy for elderly fragile patients who have a relatively high risk of bleeding and you implant on them a bioprosthetic valve?
Well, so the strategy at implantation, we try to get by with at least 1 month of anticoagulation if we can. Now you have situations where you cannot do it. When platelet count is 10,000, you're not going to give that patient either antiplatelet or anticoagulation, so you have to stop. But usually we try to get by for at least 1 month. I had recently had a very old patient, 95-year-old, who developed valve thrombosis 1 year post-TAVR, and we put her on a reduced dose of Eliquis. She still has to come back. We'll see. I think you need to be very gentle with these patients. There's clearly a risk of bleeding, including risk of intracranial bleeding.
So Dr. Swan has a question. So do you have any comments about the risk for a right valve or a left-sided valve? So whether the risk is different depending on the valve is on the right side or on the left side?
Maybe I'll start, and then Soren, you want to comment? So I think that as the data suggest, we see it in both right and left-sided valves. The patients that I worry most about, the right-sided valves, I didn't show a tricuspid bioprosthesis thrombosis, but we worry particularly in the Epstein patient population with very bad ventricles and low flow. Those patients are very high and have problems, just like Soren demonstrated, early bioprosthetic valve thrombosis. So those patients will often keep on anticoagulation for a longer period of time. But we see it both right and left-sided. Of course, I think in the congenital population, we see more right-sided prostheses than in the acquired population. So we're a little biased on the right side, but I think it's probably quite similar. The frequency is quite similar.
I completely agree with Heidi. I worry a lot about these right-sided valves, and these are small case series, so you cannot reach statistical significance on 50, 60, 80 patients. But if you do the numbers, the order would be highest incidence probably in tricuspid, followed by mitral, then followed by aortic. So I think it has to do with the velocity of flow through the valve, and I worry a lot about the right-sided valves.
So Dr. Wall from Toronto has a question. So what is the role for initiation of anticoagulation with established endocarditis, as the case that you were presenting?
Well, so I don't think I would start anticoagulation if somebody has endocarditis. We all know that that starting early with heparin in these patients will be associated with increased embolic risk, and we know that the risk of embolism decreases substantially within the first 72 hours of efficient antibiotic therapy. So in general, I do not anticoagulate the thickness of the valve when the valve is infected. Now, can you tell for a fact that this is endocarditis or this is thrombus in the context of an infectious syndrome? That becomes a judgment call.
Okay, I think Dr. Osling has a question.
Thank you very much, Heidi and Soren, for this amazing talk. With a lot presentation, a lot of take-home messages for us. So, as you said, we are implanting a lot of right-sided valves, and valves in pulmonic position, in particular in patients with impaired angiography fellow. So, do you anticoagulate? Do you routinely anticoagulate patients with a bioprosthetic pulmonic valve for 3 months and then switch them to lifelong aspirin?
Yes, we do in all of our bioprosthetic valves, unless there's an absolute contraindication for anticoagulation.
Yeah, I mean, our one of our lead surgeons, Hartzell Schaff, was on board with this aggressive anticoagulant therapy. The surgical community was surprised by results from a Danish registry showing excess mortality if you aren't anticoagulated for the aortic valve, and then they aggressively changed their stance. So yeah.
So one last question. So if you have a patient that develop valve thrombosis and you anticoagulate, develop again valve thrombosis, anticoagulate, gets that point that degenerates the valve. Let's say there's a patient with a bioprosthetic primary valve. Would you consider in that patient to put a melody, or would you consider to do a surgical valve replacement, a melody or any kind of percutaneous valve? Because you assume that it's going to have a smaller valve, higher gradient, higher risk. What is your practice?
I think it depends on the patient, the number of procedures that have been performed, and the surgical risk. And we, as you, I'm sure, have a weekly conference and review with a multidisciplinary group, but I think that's a very challenging patient population. I personally think that my experience is that if the patient has had a bioprosthetic valve thrombosis, they're at higher risk for a catheter implanted valve thrombosis, but the surgical risk is also a concern. you know, and it depends a little bit on the patient substrate. Does that patient have an identified predisposition to thrombosis? So I think that's a challenging question, and we'd need to do it on a case-by-case basis, but I would have a low threshold to sort of prefer surgically implanted valve, recognizing some of the risks.
I think the other thing I would add to what Heidi said is there's always a balance between things. So when you put a transcatheter valve inside of a valve that already thrombosed, you're going to have a cross-luminal section that's significantly lower. So the question that you need to ask yourself is the patient going to be better off with surgery and lifelong anticoagulation to prevent further valve thrombosis on a new valve, or is it going to be that the transcatheter valve will have an acceptable gradient at baseline? And really, in many ways, if you probably have a little bit of a gradient and higher flow, you may have slightly less chance of thrombosis. I don't know. So it's a balance. I agree with Heidi. Probably putting a bigger valve and anticoagulate long term is the better choice, but that depends on the patient.
Okay, I think that is 9 o'clock, and if there's no more questions, I think we're gonna close here. So I want to thank both of you, Heidi and Sorin, for really an amazing talk and for joining us today. And thank you all of you for joining us today wherever you are in the world. And see you next week. And good morning, good afternoon, or good evening, wherever you are. And for Heidi and Sorin, I hope that the elections resolve soon. All of us know the outcome. So, and see you soon. Okay.
Thank you so much for the invitation, and great to see so many friends, or at least their names and comments. So thank you so much.
Thank you, Heidi.
Thank you.
Bye-bye.
Thanks.
Bye-bye.